All right. Welcome and thank you all for coming to our virtual seminar on low back pain. My name is Tim Weinberg. I'm one of the staff physical therapists at Advanced Sports and Spine Therapy. And I'm going to be your MC for tonight's event. I'd like to start out by introducing you to our keynote speaker, Dr. Noel Tenoso, the founder of Advanced Sports and Spine Therapy. Noel is a seasoned doctor of physical therapy with 33 years of clinical experience. He is a big proponent of continuing education and has many postgraduate certifications to show for it. He is an orthopedic certified specialist. He is a certified in mechanical diagnosis and therapy. He is a certified manual therapist and recently became a certified yoga instructor. So without further ado, I'd like to pass it over to Dr. Noel Tenoso.
Thanks, Tim. When I hear how long I've been practicing, I checked what happened 33 years ago, and Ronald Reagan was president. So I've been around the block a few times. So I'd like to also introduce my panel of experts. You've already met Dr. Tim Weinberg, but I also would like to introduce Dr. Kate Martell and Dr. Jeff Cox. And they'll be manning the chat line. So if you have any questions that you can't wait till the very end that you want to post on the chat, they would be happy to answer, or you could just wait till the very end. I plan on speaking for about 20-25 minutes, so we'll get through this quickly. Take too much of your time. So at the very end, I'd like three things for you to take away from this webinar. First thing is reviewing the common myths and facts of lower back pain and sciatica. Understand that lower back pain and some of the downsides of common treatments that you'll see commonly, and a lot of you have already experienced. And then what we feel are some successful components of a successful treatment. And if you stay to the very end, and you find the information helpful, we have an offer for you to take advantage of, and something you can consider after you hear all the information. And hopefully you'll take us up on it. So who would benefit from this workshop? So if you or someone else that you care about says things like, I can't do, and you insert your appropriate functional activity. It hurts to do, and I'm afraid to do as a result of my back pain or back pain with sciatica. And hopefully we'd like to transfer over to more of a healthy language of I can do. It doesn't hurt to do anymore, and I'm more confident in doing. So let's begin with some low back statistics. Over 80 to 85% of the population will experience lower back pain of some form during their life in our country. And it's actually the #2 reason why people visit the doctor, and that's just behind respiratory infections. And persistent back pain is rarely serious, and I'll go into that in a moment. So let's look at 6 myths and facts about back pain. The first myth is persistent low back pain means something is seriously wrong. And I just mentioned that is a very rare occurrence. So what would be some examples of serious pathology? It would be like cancer. It would be infections or fractures in the back. So that rarely happens. And if you hurt your back, it takes about 3 months to heal, but this can be prolonged and protracted if you are in an environment or you have just bad habits that makes you move in an improper way, or you're sitting in a poor position for a period of time that can cause some problems. Poor sleep are some other factors that can affect pain. Stress, muscle tension, your moods, how you think about your, the pain you're having. Inactivity, especially nowadays during the pandemic, and doing unaccustomed activity. And we commonly see that with people who think that yoga might be helpful, so they practice yoga that they've never, done moves that they've never done before, and they get themselves into trouble. Fact myth number 2, getting older causes lower back pain. So if that were the case, why don't we just throw it in right now, because we're all getting older. And the fact is that, just because you're getting older, you do have more persistent aches and pains, but that doesn't mean that you can become pain-free with some evidence-based treatments. So you can be helped at any age. Something I hear commonly in the clinic is a patient would like to have an X-ray or MRI to know what the cause of pain is. But some interesting facts behind that. For one, the scans rarely show the pain generator. Even though you show problems, it doesn't mean that you have to have pain. And I'll go into that in a moment. But if you ever looked at an X-ray or MRI report that radiologists type up, you'll see words like disc bulging and protrusion, degenerative disc, joint disease. That word disease, what does that say to you? Make you feel like? Arthritis or annular tears. So these are things that when you look at that, it makes you feel like, I need somebody to go in there and fix it, because there's something definitely wrong. But if we look at this evidence that we're going to look at here in a moment, you may think differently. So should you get an MRI? And there was a study in 2014, and they looked at MRI results of people without back pain. This is without back pain. And what they found is disc degeneration and disc bulging of people who did not have back pain, but had these findings. And if you look on the left, people who have findings of disc degeneration, 37% of 20-year-olds will have it. They didn't have pain. 80% of 50-year-olds and 96% of 80-year-olds. So how about disc bulging? 30% of 20-year-olds will have it. 60% of 50-year-olds will have it, and 84% of 80-year-olds will have it, and these people didn't have pain. So what does that tell you? Just because you have those findings doesn't mean you have to have pain, but if you did have pain, are those findings of degeneration of the disc bulging, relevant to your problem? In 2016, in the Journal of Spine, which is a very respected journal for clinicians, they found that MRIs cannot predict pain location and intensity, nor can they predict surgical outcomes. So let's look at another myth. This impressive picture of core strength. I wonder how that lady does it on the left. Looks like she's floating, but she actually has her feet on the wall. I'll have to try that sometime. So I have lower back pain because I have a weak core, and I hear that frequently. But I have patients that come in with six-pack abs that you see on the left. They do crunches all the time, thinking that by building up those muscles, that gives them a suit of armor. But the evidence shows that there is no causation or correlation between weakness and the back and lower back pain. The back is actually quite resilient and durable. It could withstand a lot of things, but over a period of decades of poor posture and moving improperly, you'll eventually see some breakdown. And the fifth myth is the best cure for lower back pain are injections, surgery, and strong medications, such as opioids. And I just want to say from the beginning that we're not anti-surgery or anti-injection or medications, because they can be helpful in a lot of cases. But the evidence shows that it is not effective to have these procedures and medication for persistent lower back pain in the long run. So you never get a full resolution of your problem. And with surgery, there are all sorts of risks to try surgery first, and with no guarantee with a good outcome. So, why not try something a little bit more conservative before you jump into having surgery? Now, there are cases where surgery you have to have it immediately, but that's a very rare case. How about moving and then you have pain, and how you interpret that pain when you do move? Is it harmful or is it something else? The fact is, if you move and you have pain, that means that you have mechanical pain. So there are movements that will cause you pain, but there are also movements that may reduce your pain. And with a very thorough clinical examination, that may often lead us to what kind of a treatment plan that you might have. So sources of pain. Everybody wants to know where the source of pain is. And like I mentioned, that most lower back pain that comes into us are mechanical in nature, not serious. And mechanical pain is movement and position oriented. So there are structures that can be prone to being injured and be a source of pain, such as the vertebrae, disc, nerves could be entrapped and impinged, ligaments can be under stress, and muscle tendons can be also under stress. But how do you know which one is the cause of pain or the source of pain? So medicine has all sorts of clinical tests. But just keep in mind that the back has a wide distribution of pain receptors in all these structures. And so when you do these tests, it's very inconsistent and difficult to find what individual structures are at fault. So a lot of these tests are unreliable. So what the heck are we supposed to do? It's like, oh crap, I tried all these things, surgery, injections, medications, some physical therapy, but not finding a good answer. So if most back pain is mechanical, how about exploring a movement solution? And I would like to propose that a low risk solution would be something that's more natural and healing, not relying on anything, lotions or potions or medications, no injections or surgery. So if we have a mechanical problem, why don't we investigate a mechanical solution to our problem? So about 22 years ago, I took a course in what was called Mechanical Diagnosis and Therapy. In short, it's called MDT, or the McKinsey method, since it was started by a physiotherapist in New Zealand named Robin McKinsey. And the picture on the right is a triangle with the base of the triangle being assessment. So that's the foundation of treating our patients. So getting a thorough, detailed, history, and then doing a movement and examination, which drives a mechanical diagnosis. Not so much a structural problem, but what kind of mechanical diagnosis and movement diagnosis do we have? Oops. And then that drives treatment, and then often leads to a better outcome. So how is mechanical diagnosis and therapy different? So there's examination of movement and positions. And then one of the strong points of MDT is centralizations, and I'll go into that here in a moment. And once you figure out what your mechanical problem is, then we give you a movement prescription based on our examination to address your specific injury. So what is centralization? So on the diagram on the right, centralization, if you look at that body diagram on the far left, is back pain with leg pain going all the way down to the foot, what we call sciatica. And as we're examining someone and putting in, doing movements in different positions, we may see that pain start to recede, moving up to the knee, going up to the thigh, up to the hip over a period of time, maybe all the way into the back, getting rid of that leg pain, and eventually settling into the lower back and eventually abolishing that pain. So that is what we call centralization. And we see that with up to about 74% of our patients. So a good amount of our patients demonstrate this. And 70% of them show a movement direction, what we call a directional preference of movement, that will produce this. And if we see this, that's a really good sign that you'll get better. So repeated movements, and these are some examples that we might do in therapy. that we would explore during an examination that may produce centralization. And there's also a lot of evidence to show that we have better outcomes once we found that specific movement and have that patient do that very frequently throughout the day. So doesn't matter which exercise that you do. So this is a great study by Audrey Long, a physical therapist in Canada back in 2004. And she looked at 312 patients. 75% of those patients exhibited a directional preference. So one of these movements off to the right centralized the patient's pain, got it out of their leg or out of their hip and into their back and reduced their pain in the back eventually. So what she did was took this group of patients with a directional preference and divided them up into 3 groups. The first group, she kept the patients that were benefiting from a certain exercise, let's say D, where they were doing this, looks like a modified push-up and producing an arch in the lower back. She put another group that was opposite of that position. So they were bending forward, let's say that looks like that letter A exercise. And then the third group, they were doing some general back exercises, so that were evidence-based. And the findings were interesting. Of the patients that continued with doing the exercise that centralized their pain, 94% of them resolved or improved, and 6% were no different. The other groups either withdrew or worsened with those particular exercises. So doing a specific customized exercise based on your can lead to a successful outcome. So MDT patient-driven management relies on a really good thorough assessment, decoding your problem, meaning coming to some mechanical classification or diagnosis, giving you a customized exercise program that would help promote healing and actually empowers the patient to self-manage their problem, rather than relying always on the clinician and coming into therapy to do it. So I'll give you a few examples of patients that I saw. One is this 58-year-old male who was a very competitive golfer, and he played tournaments monthly, traveling all across the country. He was also an executive for a company. And his story was he had lower back pain and sciatica, and he was seen by 3 surgeons that all told him that he needed surgery. Now his story is that he finished playing golf, he got into a car with his buddies, got trapped and sitting in the back, and the back seat was fairly cramped, so his knees were up near his chest. And as they were going to where they were going, they got stuck in traffic, so he was stuck in that position for over an hour and eventually developed this back and leg pain. So his wife talked him into coming to therapy, and what we found is that his pain centralized with this picture on the right, where the woman is doing this yoga-like movement where you're doing this little twisting movement, and that centralizes pain, but he still had pain in his back. Now, he did that exercise frequently throughout the day. He couldn't work, so he got in this position because it gave him some relief. Eventually, we changed him to this exercise that's down below called the press up, and that eventually abolished his pain. We also had to educate him on proper posture and body mechanics, and he had a very successful outcome. My next patient was a 39-year-old mother of 3 kids, and this one was very, very interesting because she didn't have back pain. She only had knee pain, and she had several years of knee pain with no trauma. And her pain got worse in her knee during the pandemic because she stayed at home with her kids, and she sat with them while they were on the computer for a long period of time. And so when she saw the doctor, they did an MRI of her knee, and they noticed this defect in her anterior cruciate ligament of her knee. And they were talking surgery to do an exploratory surgery to see what was going on. Her mother talked her into coming into therapy just for a consult. And her history was interesting because she only experienced knee pain after she sat and she got up to a standing position. And then when she walked, the pain went away. So that made me suspect that maybe this is a more bad posture, spinal driven type of problem. She did the exercises down off to the right there, where the woman's doing that press up, educated her on posture and body mechanics, and she had a happy ending and outcome to her problem and avoided surgery. So I talked about patients doing the directional preference exercise, or they're doing one exercise. And people ask me, well, when do I start doing, regular exercises? So our criteria is when things start to centralize or are centralizing, are stable, and they work closely with a clinician and making sure that they're sitting properly, getting up frequently, and picking up things in an appropriate way and not using these poor mechanics like in that picture. And then we can start adding different types of exercises as long as the pain is centralizing and going away. And we'll start layering on normal exercises so it mimics more or less fitness, addressing the mobility impairments and maybe the lack of strength that they may be having as a result of having pain for so long. I want to talk a little bit about physical therapy and MDT with more invasive procedures like injection surgery. Now, this was an interesting study done in Denmark, published in 2009, that looked at spinal surgery and MDT. And what they found was they looked at surgical rates before MDT was introduced, and then surgical rates after MDT was introduced into a population. And they did that in a 10-year period, and the findings were interesting. There was a 50% reduction in spinal fusion rates and a 67% reduction in disc surgery. So people still needed surgery, but maybe not as frequently as they needed. So MDT did a great job of helping surgeons select the appropriate candidates for surgery. So take-home message for surgery is it's usually not the first option. How about epidural steroid injections or spinal injections with MDT? Now, if a patient saw us first and we noticed that they weren't responding, so it may not be mechanical at first, it may be more inflammatory. So working with a physician that does epidurals can be very helpful. Get them out of pain, and then bring them back to therapy to resolve the underlying mechanical problem and the lifestyle or movement problems that they may be having, and having that addressed and improved. So after looking at all this, what do you think a successful treatment should look like? In our opinion, it should be individualized. It should be a whole body perspective, looking at not just the person, but also the task and the environment that that person is working in. Education and empowering, one-on-one. We feel that working one-on-one with a clinician and not being handed off to someone less trained, like a tech, and only seeing the physical therapist for 10 to 15 minutes. And there's a point where, yeah, sometimes palliative care can be helpful, where you're just getting more passive care, but we like to be more focused on movement and exercise, but the appropriate movement and exercise is key. So after hearing all my information, still remember all that I've talked about, maybe very difficult. We have a book that you all hopefully have downloaded that can help. But this is all just general information and ideas about back care. And we don't know what your specific challenges are, because everybody's unique. And so in order to address everyone who's attending here, your special circumstance and problems, we're offering a free consultation. And in our consultation, here's what you can expect. It'll be a 30-minute one-on-one in person, or it could be virtual session with a physical therapist. And we'd like to hear what you've gone through, what some of the struggles you've had, obstacles and some challenges that we can see if we can be of some help. And plan of care. So after we hear your story, we can map out and tell you what the course of care could look like in physical therapy, what kind of timeline, and what you can expect in terms of what kind of movement interventions we could see after we do a thorough examination. So just to recap what we've talked about, some of the myth busters we addressed, how MDT is an assessment system to help us diagnose and giving you an appropriate movement prescription, and what an individualized treatment solution could look like. So I want to round out back to the very beginning where we had the can't language. It hurts to do, I'm afraid to do. And there's a lot of can't these days with the pandemic, but in terms of your back pain, look at what are some of the obstacles and barriers that you might have, or fear. You could be your own worst enemy. And also some of the things that you think that are helping, but may not be helping at all, and may be working against you. And we want to move you to can, and getting you more comfortable and capable and confident, and return to what's important in your life. And what would that feel like if you could do that? So as clinicians, we want to work or help you and walk alongside you and be the guide and the mentor to get you to can from can't. So it's still all about you.
So I'm going to talk a little bit about advanced sports and spine therapy. So we are a privately owned outpatient physical therapy clinic in the Portland, Oregon area. We provide one-on-one appointments with a licensed physical therapist. You will not work with physical therapist assistants or aides, so it will be one-on-one, high-quality care. We're the only mechanical diagnosis and therapy certified clinic in the state of Oregon. All providers have the same high-level training in the MDT system, providing quality care from all providers regardless of your condition. We offer a wide variety of physical therapy services. We treat individuals of all ages with back pain, neck pain, and nerve pain. We love to work with athletes and those that are injured in sports, such as those that hurt their shoulder, knee, ankle, or even those that suffer from concussions. We work with aging adults who need assistance with balance, strength, and mobility training. We work pre and post-surgical orthopedic. We work pre and post-surgery with patients. And we also offer pelvic health specialty. We have two great physical therapists at our Westland location who are certified in pelvic health. And finally, we offer vestibular system rehabilitation for those with dizziness, vertigo, and balance troubles. All right, so as I mentioned, we are located in the Portland area. We have a location in Westland, Wilsonville, and one in Northwest Portland. So if you have any questions or live in these areas and would like to come in and use that free consultation, these are our phone numbers for each of those locations.
I think there was a question about what if my job requires or puts me in bad posture? Yes, posture is just a set of principles, and giving you some education on what the proper sitting positions are or standing positions. But the bottom line is being even in a good posture is not great if you're there for hours. So I actually encourage people to get up every 25 to 30 minutes and just move around briefly. It could be 15 to 30 seconds, and then go back to sitting. And these days with people on, on Zoom calls like this, are sitting for hours and hours. They're sitting in workstations at their home and no longer at the office that are not designed for them to work for long periods of time. So I've seen a lot more of that coming into the office as people's home offices are just not designed to be there for a long period of time. So yes, and if you're having some discomfort in your back as a result of these poor postures, that's a real easy, straightforward resolution of that problem.
Yeah, and at the consultation, we'd be able to kind of hear what you do for work, see what kinds of things aggravate your symptoms, and then kind of brainstorm and come up with ideas to help alleviate that and help you overcome the back pain associated with work. So I work from home now and I work at a standing desk, but I do still have lots of discomfort. Do you think that press ups every hour or so would be helpful? What do you think, Noel?
Yeah, if you have that capability of getting down on the ground and doing press ups, absolutely, it could help. Depending on, even a good thing can be irritating if you do it too much. So doing it every hour may be a little much. So you may even want to consider, if you're not having any problems and you're doing it just for, maintenance or prophylactic kind of purposes, maybe doing it 2 or 3 times in the morning and 2 or 3 times in the afternoon and evening might be more beneficial. And I also encourage people to walk if you are more in a sedentary position. So press ups are really great and helpful, but moving around, such as walking, would be, I think, even more helpful.
And just like Noel mentioned earlier, everyone responds in a unique manner in terms of what their directional preference is. A lot of people do respond to press ups and extensions, but not everybody might require a different movement. So that's where the consultation is beneficial, just to see what your unique directional preference would be.
We got another question?
I had difficulty raising from bed in the morning 2 days last week due to extreme pain, but now it's gone away.
Well, that's good news, but there's always a chance that this problem could come back. And knowing what the root cause to start it off with is really important, because then you'll be not knowing what made it better or made it worse. So it might be helpful to explore with you and finding out exactly what kind of problem you have, and then addressing that so you have a clear understanding on self-management strategy on how to resolve that problem. I think a lot of people live by, this episodic kind of problem where it comes and goes. And I just had somebody today who, instead of back problems, it was neck problems. And he goes, sometimes it's there and sometimes it's not. I can't tell you what causes it. And so he just lives in kind of fear, and he kind of feels that when it comes on, he's just like bracing himself. And what we figured out is that he felt worse when he got up in the morning, and it was because he slept on his stomach, cranking his neck to one side for hours and hours. And when he woke up in the morning, his neck was trashed. And so he didn't always sleep on his stomach, but when he did, that's what we figured out, is that's when he got into problems. I had a unique solution for that too.
What'd you tell him to do?
Well, so people with sleep apnea, a lot of times have problems sleeping on their back, and that obstructs their breathing. And so there's this cheap, low-tech device called a t-shirt and tennis balls that you could put in your a little pocket. You could buy it off of Amazon, and put it on your back. And when you sleep at night and you roll onto your back, it gets you, when the tennis balls hit you, puts pressure on your back, it gets you off your back. So I told him to get one of those t-shirts and put the tennis balls in the front. So I thought that was, and he thought that was a real novel approach.
I like it.
Next question is, what would a free consult include and how to claim? So, so a free consult, it will be like a 30 to 45 minute one-on-one with a physical therapist, and we would hear your story and take down some history, see what things you're struggling with, how long has it been there, what things make it worse, what things can make it better, and try to get a good picture of clinically what's going on. And then based on what you tell us, and maybe we'll have you move around a little bit, then we'll propose what a treatment plan could look like, or we call a plan of care, and map that out for you. And then, so that's what that would look like. And you would claim that by just contacting our offices, calls on the phone, which I encourage you to do, and set up a consult. So you've heard about the consult through the webinar tonight, and schedule an appointment. Okay. Thanks again, everybody.
Thanks, guys.